I will introduce the first speaker, Dr. Monika Malhotra is a consultant IVF and gynecologist at the Emirate Hospital, Abu Dhabi and Dubai. She was a former clinical fellow in reproductive medicine and IVF. She acquired her membership of Royal College of Obstetrics and Gynecology in 2004. She has also been a clinical fellow in gynecology and endoscopy at Royal Free Hospital, London. She has many index publications in various topics, including infertility and IVF. Today she will present his topic about the quality of the duration of gonadotropin stimulation effect on embryo quality. Please, Monika.
Good morning, ladies and gentlemen. I'm really honored to be here today. We're going to talk today about stimulation, which is obviously the mainstay of in vitro fertilization. And however the world might talk about mild stimulation, natural cycles, modified natural cycles, stimulation will still remain an integral part of IVF. Today we're going to talk about in the race to develop a fittest, finest, and fastest therapy to success of IVF, are we really tampering too much? And are there any perils of stimulation and the pros and cons? And we'll go through it with you today. Now, what decides the fate of the embryo? The oocyte nuclear and the cytoplasmic maturation, its own morphology and the developmental potential, the follicular microenvironment that it is exposed to during its stimulation, and the topic that we're going to focus on is the duration of controlled ovarian hyperstimulation during the follicular development. And as I just said, the nuclear and the cytoplasmic maturity that accompanies the follicular development plays a crucial role in facilitating the fertilization and early stages of embryo development. There have been studies where natural cycles have been compared to stimulated cycles to see whether stimulation itself has an adverse effect. In most of the animal studies, some adverse effects have been shown, where it has an impact over apoptosis in the granulosa cells. Repeated stimulation in mice led to increased frequency of spindle defects and increase in chromosomal errors, and this was again a comparison with the natural cycles. Let us talk about human studies. The results have been a bit inconsistent. It definitely affects the oocyte competence and the embryo development and viability. But a lot of studies, especially the older ones, said that more than retrieval of 10 oocytes itself correlated with lower quality and chance of conceiving due to reduced fertilization rates probably. In some of the recent studies, no effect on the normal cleavage rates, morphology, developmental capacity, or degree of fragmentation has been seen by stimulation. It has been proposed that there will be some detrimental effects on the oogenesis, embryo quality, and endometrial receptivity, and it definitely has an impact on aneuploidy and embryo development. We'll see how that happens. It's usually, most of the time, mitotic segregation disorders which are accompanying stimulation most of the times. Higher doses of FSH versus milder stimulation would probably produce increased proportion of aneuploid embryos, which is again postulated, with increase in mitotic and meiotic chromosome 21 cell division errors. Repeated rounds of stimulation in patients have again been postulated to compromise oocyte competence and implantation rates. And implantation rates would decline from cycle 1 to 2 and then plateau from cycle 3 to 5. Now, what happens with the duration of stimulation? Now, this is a study published in Fertility Sterility 2006, where there was no impact on the clinical pregnancy outcome in IVF with the duration of stimulation. There was no correlation between the number of days of stimulation and the number of egg retrieved and fertilization rates. Extremes of stimulation duration, that is, say, less than 8 days or more than 12 days, did not demonstrate any adverse outcomes on the oocyte or the embryo quality. And there was no difference in the length of stimulation between good and poor reserve patients in pregnant or non-pregnant cycles. In another study from Turkey, there was an analysis of 615 women, which was a retrospective analysis, and they divided them into 3 groups of less than 8, 9 to 10, more than 11 days of stimulation, where less than 9 days of COH, that is wherein stimulation, resulted in more embryos with more than 10% fragmentation. And there was a comparable number of 6-cell embryos in all the 3 groups, but similar average number of embryos were transferred on day 3. So again, it did not really impact what was the duration of stimulation in this study. The group with the shortest duration, that is less than 8 days, did show a higher percentage of embryos with fragmentation, but it was not clinically significant except for the embryos with no fragmentation. So the duration of COH probably affects the degree of fragmentation, which basically reflects loss of regulatory proteins from the blastomeres. There's a loss of essential organs like mitochondria and might represent an incomplete cytokinesis. Now, some of the older studies where the duration was more than 13 days strongly decreased the possibility of having at least one oocyte, which probably means that these are patients with poor reserve were stimulated and then received higher doses until at least one oocyte was retrieved. The longest follicular stimulation with a mean of 14.5 resulted in lower number compared to the one with lesser, that is about 12.8 days of stimulation in another study. This is again a study where 278 women were analyzed in a long protocol, and they had division in categories on the basis of the serum estradiol instead of exactly the duration of stimulation, but similar metaphase 2 oocytes, fertilization rates, distribution of blastomeres per embryo were seen in all the groups. There was no compromise whatsoever seen on the oocyte and the embryo quality with excessive response or the length of stimulation. And also, it did not affect the nuclear maturity of the oocytes. Talking about supraphysiological estradiol levels, in the same study, no significant difference in the pregnancy rate, implantation rates, multiple pregnancy rates was seen. And the number of the transferable embryos did not get reduced in the highest estradiol group, which is the extreme supraphysiological group. Now, this is an in vitro study versus the in vivo studies that I was talking about. This was in a mouse model where they saw a direct toxic effect of supraphysiological estradiol levels causing direct effect on the cleavage stage embryos affecting implantation. It might have again a role in reducing the endometrial receptivity as well, reducing the implantation rates finally. It does support to some degree milder stimulations and delayed transfer of the embryos if the E2s are found high. Also, again, in an animal study, lower number of blastocysts were retrieved compared to control, and lower mean cell numbers were found in the cleavage stage embryos. And this embryo adhesion assay again showed a direct toxic effect on the embryos, but these are in vitro studies. You should just make a note of that. Now, although OHS is a completely different entity, and we do get often a lot of immature oocytes, even though the numbers might be high, this is something which showed that OHSS itself could correlate with a poor oocyte quality and low fertilization rate. And in this study, the mean E2 levels on the day of HCG were 6,700 approximately in picograms per ml. Another interesting study in which a man suffering from severe male factor infertility had 2 wives. One of them had OHSS and had poor fertilization rate. Her embryos were frozen. She did not undergo transfer in that cycle, did not get pregnant eventually in the frozen cycle, possibly affecting the oocyte quality. Whereas the other wife, who had a normal response, a normal fertilization rate, had conceived in the same cycle. So 2 women, same factor of infertility, could have different responses and conception rates if there is an excessive extreme response. There is a study from South Korea which has actually told us an optimal level of estradiol of about 3,000 to 4,000, which is essential for a successful pregnancy in women less than 38 years of age, whereas they've quoted a level of 2,000 to 3,000 in more than 38 years of age, which is interesting. A Spanish study showed an inverse correlation between high estradiol and pregnancy rates again, and the optimal level of estradiol is quoted as 1,000 to 4,000 picograms per ml for optimal implantation rates. A study with around 1196 cycles from China had again shown that there was no difference in the oocytes retrieved under fertilization rates, and high estradiol levels have not were detrimental possibly to implantation, but not to the quality of oocytes itself. So probably it's an endometrial receptivity factor working there, but not actually affecting the oocytes and embryos directly. Now, we at Faki IVF perform about 1,200 cycles per annum in the UAE, we just sampled like about 246 cases. It's also a premier center for PGD in the UAE. This was a retrospective analysis with the short protocol. We took about 246 patients, all ICSI cycles with male factor, which did not require surgical retrieval, and aged less than 40 years. The mean was 35 years approximately. Now, this chart is showing you the range of stimulation days, which was about 3 to 20 days. The mean was about 9 days. These are the different number of patients in the category with the different percentages. And of course, the maximum number of patients fell in the category of 7 to 9 days of stimulation. The number of eggs retrieved, as you can see, the mean number did not differ in any of the groups, and this was not found to be clinically significant. It was pretty much similar, ranging from, say, 10.7 to 11.9, but very similar in all the groups. Talking about the mean number of mature oocytes, again, did not differ in the various groups, as you can see, and the differences, whatever might be, were not clinically or statistically significant. This is just a chart showing you the similar observation where the number of mean oocytes, and this other graph bar shows you the number of mature oocytes. So did not differ, the results not being statistically significant. Now, the fertilization rates there was no major trend, although you would see the maximum fertilization rate was seen in the less than 7-day stimulation, which may not be explained very well, but there was no trend at all, there was no difference. The average fertilization rate in the unit was about 61%. These are the pregnancy rates where the maximum pregnancy rate was seen in the stimulation days 7 to 9. But again, this was not, the differences were not found to be clinically or statistically significant at all. This is a graph showing you the fertilization rate, and the second graph shows you the pregnancy, the clinical pregnancy rates with respect to the stimulation days. And again, no differences at all in this group of patients. Now, the percentage of grade 1 embryos and the grading system that our embryologist uses is basically based on, as anywhere else in the world, the number of blastomeres, the symmetry of blastomeres, and the fragmentation degree. And as you can see, there was no trend, and the differences found were not significant at all. It was pretty much very similar throughout all days of stimulation. Even when it exceeded more than 11 days, up to 20 days, the percentage of the high quality embryos remained pretty much the same. The mean E2 levels, interestingly, were also same in all the groups. So it was not like a very high supraphysiological levels in the more than 11 stimulation days. It was all very similar, not significant. And the FSH dose was also similar in all the 4 groups, say about 30 ampules per patient of pure FSH. Now, we also divided the patients on the basis of estradiol, and we had 4 categories of less than 1,500, 1,500 to say 2,499, 2,500 to 3,999, and more than 4,000. Now, you would see that there is an increasing trend in the number of mature oocytes from the least estradiol to the highest estradiol group. The fertilization rates remained the same. As we've shown before, the clinical pregnancy rates remain the same. So although the number of mature oocytes went up, The pregnancy rate remained not clinically significant, though the maximum was achieved in the group of 2,500 to 3,999 picograms. So possibly this is our optimal level for conception in our group of patients, as described previously in a South Korean study. Now, this was the only value or the observation which was found to be clinically significant in our data, where the only, although the clinical pregnancy rates remained the same in all the groups, the only thing which differed was the implantation rates. So again, in the category where the maximum pregnancy rates was found, the implantation rates were obviously the maximum, and that was found to be clinically and statistically significant compared to all other groups. So this is probably the optimal level which either can be aimed at, or the patients can be kept in that kind of a range to achieve the maximum implantation and clinical pregnancy rates possible. So my conclusions are that the overall impact of stimulation is inevitable. There will be pros and cons. The world is moving towards natural cycles and modified natural cycles and milder stimulations. But stimulation will remain the mainstay of IVF. On the whole, with all the previous studies and our own observation, the duration did not impact the oocyte number, fertilization rate, quality of embryo, and the clinical pregnancy rates. The extremes of duration of stimulation may have some impact on the final oocyte number and fragmentation of embryos, as described in some of the previous studies. Though most of them are actually in vitro studies, this was not seen in our data analysis. The best implantation rates were seen in the estradiol category of 2,000 to 3,999 picograms per ml. And this is where the endometrial receptivity may play a role. And there is a concept of delayed endometrial, delayed glandular and advanced stromal maturation, which happens with very high estradiol levels, which is kept to the lowest and probably the most synchronous in this kind of estradiol range. So possibly aim at this. The duration needs to be obviously flexible based on the scans and serum estradiol monitoring and cannot be aimed at a particular number of days. Extended durations may not have an adverse effect provided the estradiol is in the optimal range. So stimulation, is it a blessing or a curse? You need to really carefully now look at the human beings that are coming out of the first IVF cycles and see the effect of ovarian stimulation on the first generation of the ART-generated children who are there now. And obviously, a lot of caution has to be used with novel ovarian stimulating regimens for IVF. Thank you very much, and for those who had a nap, can wake up.